Okay, let's get started. In case you don't know, I'm John Jamad in the Annenberg School, and I'm happy to introduce today's speaker, Neal Lesh. Neal is the Chief Strategy Officer of Dimagi Incorporated. He received a PhD in computer science from the University of Washington in 1998 and a master's in public health from the Harvard School of Public Health. From 2005 to 2009, he lived in East and Southern Africa, working on information systems for projects including large-scale AIDS treatment programs, rural hospitals, and research projects. His primary focus now is on CommCare project, a phone-based tool for use by community health workers in low-income countries. Please join me in welcoming Neal.
Thanks a lot, John, and thanks to the school and to Deepti for arranging this talk. It's really great to be here. The title of my talk is Phone-Based Tools for Community Health Workers. An alternative title might be a view from the inside of the mHealth bubble. As you might have heard from previous talks, there's really just a tremendous amount of excitement and not a small amount of hype around the idea of using cell phones to improve healthcare delivery, it's a really exciting time. There's a lot of very high expectations. I think overall it's fun, and it gives you kind of some new opportunities to have all this excitement around you. It's a little bit tougher, I think, to have a good perspective on it all. Just a little bit of brief review of me, although a lot of this was covered by my intro. Back in '98, I got a PhD in computers, and then after several years of pretty academic work in artificial intelligence and such, I really shifted careers and thought I was leaving computer science. I spent about 9 months getting a master in public health. And I've actually been used to, I used to talk to a lot of computer science groups. Now I've been talking to mostly health groups. If I start using health terminology that isn't clear, please raise your hand and ask me to explain it. I think my jargon has kind of shifted around in my head. And then, what happened after I left, I kind of then learned about ICTD, and so computer science kind of caught up with me again, and I started doing more things with it. Right after I got my MPH, I spent a few years really bouncing around a bunch of different countries and projects, working on different systems, mostly for short periods of time. Somewhere in there, I started focusing on this one system, CommCare, which I'll tell you more about later. And then really in the last year, I've been focusing on how to productionalize it and scale it up. And we'll see, we're still basically in pilot stage. We went from a few pilots now to lots of pilots and standardized approaches. We feel like we're on the verge of scale. So this is the perspective just before, or with the expectation that the next year or two is going to reach the high levels. And one of the quotes that I heard early, somewhere around 2004, 2005, was from Vikram Kumar. It's a very the co-founder of the company I work for. It's a really inspirational quote to me. This idea that we could aspire. It was right after the internet bubble that he was talking about this, and I think I've learned a lot about. I've gone through, been party to a few bubbles along the way, but it was this idea you could read that rather than trying to measure success by how much money you can make or trying to earn $1 million, you could try to help a large number of people. And then just a few caveats before I go through the rest of the talk. There's also, there's a lot of mixed motivations. I think we are driven by the mission and that, but if you look at all the mHealth groups, and there's quite a bunch of us building mobile phones for health products, we're also driven by our egos and wanting to get success. And I don't know if you know the Pinky and the Brain cartoon, but it starts out with these two mice. The big mouse says to the little mouse every time, what are we going to do today? The little mouse says, well, same thing we're doing every day, make a plan to take over the world. And I think this is like a good motivation. It's Google was a couple of small guys trying to take over the world, and Amazon and a lot of systems that have become big start out with kind of just unrealistic ambition and sense of grandeur. And a lot of things fail, a lot of things come good. I think what I would take from my last few years is that there's no idea or kind of virtue or altruism that's good enough to make success happen in this field. There's just a lot of stuff you have to go through, funding, partnerships, a lot of politics, this kind of stuff. And so you kind of need both. You need some sense of altruism plus some sense of just kind of ambition or championship or wanting to see your idea drive. And I think the combination, in a more perfect world, you could have just the altruism drive it, and I think that probably isn't enough, that people often have to be attached to their ideas and have their ideas, want to see those succeed is often how you're going to get to big scale. And then as I said at the beginning, I think we are in a little bit of a bubble of enthusiasm. And so, we don't know when it's going to burst or what will happen afterwards. I think all this, kind of this perspective that I'm saying should be taken with a little bit of a grain of salt, that we're in this kind of area where it's really very, there's just so much excitement around doing this that I think it's a little hard to know what it's really going to look like when we look back in a few years. For the rest of the talk, I'm going to give a little bit of background both on health and how ICTD can focus in on it. Then describe some of the kind of stories and lessons from those first few years when I was bouncing around a bunch of different projects, and then talk about scaling and evaluating this CommCare project, and then finish with some Q&A. And just to start, I sort of dusted off a few old slides for this talk, just to give a little sense of public health and global health. There's just a little puzzle of if you look at the annual death rates of two of our neighbor countries, Canada and Mexico, you might be surprised that a lot more people die per 1,000 people in Canada than in Mexico, even though you would sort of expect Canada to be a wealthier, healthier country. Does anybody know why this is true? Yes, that's exactly right. So Canadians are older than Mexicans by and large, and older people will have a higher death ratio. And so this is just to say that the goal of public health or health interventions isn't, it's to make people live longer lives, and none of us are getting out of this alive. So you can't really prevent death. You just could delay it. And when you think about things like HIV or maternal mortality, why they're so devastating to societies is because they kill people at a very young age. And then another sort of just key concept of public health is about risk factors, risk factors for lung cancer is smoking, that kind of thing. And then that poverty is really one of the driving risk factors for bad health. And a common example is, this is some real data from the Titanic sinking, which is that if you were in first class on the Titanic, you had a much better chance of surviving the ride. And second class less, and third class less. So it's a good dose-response relationship, where the more you paid for your ticket, the more likely you were to survive it. This data, I think, is accurate. It's a little bit misleading because there were more men in first class, and a sinking ship in the 1900s is one of the few places, unfortunately, where it's protective to be a woman or child. And so that's a little bit why some of the first class people were given priority. But taking the same concept that wealth equals health, it really plays out in pretty incredible ways in the world today. There's just, I think the people living in poverty aren't dramatically worse than they were 1,000 years ago. And there's things that are different, but there's an unprecedented level of inequity in the world where the richest billion people have 100 times more wealth than the poorest billion. And this then corresponds to also just extreme health inequities. Just the number of years you're likely to live if you're born in one of the richest billion is almost 70 or 80% more than in the lowest billion. And infant mortality is just inexcusably high in poor countries. 95 per 1,000 births in some places, whereas in reference with proper approaches, you could get it down to 5 per 1,000 births. And maternal mortality is similarly just really high. In countries with high maternal mortality, a woman might have a 5% lifetime risk of dying from pregnancy, given that fertility rates are high. And just to give a little more sort of context to the kinds of areas that people are often trying to apply interventions, this is a picture of a rural dispensary in Tanzania. This is maybe before it opens. There's a lot of women who have brought their sick children for care at the clinic. They may have walked quite a ways to get there. The clinic may or may not have a clinician that day, may or may not have electricity that day, may or may not have medicines that day. So there's a lot of kind of tough factors. What's makes the situation a little bit addressable is that the things that are causing death are not that hard to address. I mean, there's underlying causes that are tough, like poverty and malnutrition, but people are dying of pneumonia or diarrhea, or malaria, all things that are pretty preventable and treatable if treated in time, inexpensively. And there are a lot of good proven interventions that, like, if you deploy them, they're at least under research conditions and strongly, you get big health effects. I don't have numbers but this will come up a bit later. There's a protocol called the Integrated Management of Childhood Illness, IMCI, which describes how to, for kids that have a cough or diarrhea or fever, here's the questions to ask. Like, here's 5 questions to ask if they have a cough, how long have they coughed, is there blood, this kind of thing. And then from that, recommends a treatment. And if you follow those correctly, you significantly reduce child mortality. And I think it saves money, as they've shown some good rigorous studies. And then there's other studies that show, like, properly run community health worker program can reduce neonatal mortality by 30 to 50% with modest other kind of infrastructure investments. And the challenge is just that these things are hard to implement well. It's easy when you have like a big research study and you could manage it really well, but it's hard to deploy these kind of interventions that have been proven in research conditions or small, in relatively small cases at scale. And so there's been a lot of work over the last few years to build these, mobile health or mHealth applications using SMS or mobile applications or more sophisticated applications. I've listed some of the popular ones here just to give kind of a flavor of them. I think part of the property of being in the bubble is that there's kind of a lot of chaos. It's hard to know what the difference between the groups are. People are moving fast, and so there's hard to even keep track, even for those of us kind of in the middle of it, about everything that's going on. And then just to jump ahead a little bit, so before, I'll go into this in more depth later, but just before going into some of the details, like I watched Kentara's speech or on the web that he gave last time. Have many of you been here for the series? Have you sort of seen Kentara's talk about what makes ICTD work? And so with that in mind, I was thinking a little bit about what we're hoping for out of CommCare. So I'll tell you more later, but for now, just know that CommCare is a tool that runs on a phone that we give to community health workers, CHWs. And basically what we're hoping is, well, if a community health worker using CommCare will be a better community health worker for having it. And I think you could, after looking at Kentara's talk, I thought, well, that maybe is a little bit too simple. And you might have to say, well, it's not going to help everybody. If you're kind of a good community health worker, then CommCare can make you stronger. But if you're not getting support, if you don't have resources, if you're too busy, if you're not able to do your job, for all those reasons, CommCare is probably likely just to be a distraction and can make you worse. And that's not terrible. I mean, I think you could say, well, you just have to be careful about who to deploy it to, and certainly that there's no illusion that the technology will do anything more than strengthen systems. It's not going to solve problems that have a lot of other things going on. Even this seems a little bit wrong and unsatisfying. One reason is that it's really not good or bad CHWs to begin with, and you're not really affecting community health workers one at a time. So a slightly better approach would be that if you had a well-functioning community health worker program and we add CommCare to it, then you'll get a better CHW program. And similarly, if it's a poorly functioning one, maybe that's something we can help with. Also not fully satisfying, I'd say, because you don't want to be helping just the good programs. You want to be somehow reaching other ones. And so I think I'm still working through this, but what I ended up with was just that, I think our goal is that if we figure out how to integrate CommCare into community health worker programs, we want to be able to strengthen them. And then the real questions I think we're working on is, well, how do you integrate CommCare? What's the right way to do it? And how do we make CommCare better? So again, that's without any knowledge of what CommCare is, but just gives you kind of a framing of what are the kind of questions we're asking. So that's the first part of the talk of background. I didn't say this before, but feel free to jump in with comments or questions. Very happy to have an interactive talk. There'll be plenty of time at the end, but happy to have some discussion along the way as well. And so to start off this section, though, I've listed out some of the lessons or kind of the mantras that we've told ourselves over the time, and I'll back up some of these, not all of them, through stories. And I think I've seen a lot of talks where people put lessons. These are sort of a little bit of maybe the flip side of the myths of ICTD that Kentara spoke about. And I'd say these lessons aren't very useful by themselves. They're kind of obvious. They're sort of the things you might have learned in kindergarten. In kindergarten, we didn't call it open source. We called it sharing. But it's the same basic idea. And what really it is that these are the lessons. They just take, it takes judgment and experience and practice to be able to apply these effectively. It's hard to know like what's, how do you, like, it is smart not to automate a broken system, and I'll talk a little bit more about why not to automate an idealized one. But in any given situation, it's hard to know like what that means or get guidance just from knowing it. And so the point of these next few slides is just to sort of illustrate some of the things that I've learned over the time. And so the stuff that I started working on, I don't do it so much now, is electronic medical record systems, mostly in East Africa where I was, and mostly for HIV treatment programs. And the way that almost all the programs worked back in 2007 around time, and I think probably still today, and the kind of programs I work with is all the interaction is with paper. So doctors are seeing patients and then they're filling out paper forms. And then those paper forms go to a data center where data clerks type in those forms. And then those are used to produce reports. Those reports in the extreme case are external reports, maybe going to funding. A lot of the impetus behind electronic health systems was the big reporting needs for the large HIV treatment programs that got rolled out a while back. But often there's more also helpful reports that go to program managers to help them allocate resources, or reports that go, individual patient reports that get used by the clinician when the patient comes next time. And a lot of what I did early on in my work was try to build useful reports out of these systems. And so like one of my first places I worked was in Tanzania in a large HIV program, and this is a kind of an excellent and useless report that I created, which was like a one-page summary of each patient of a patient. It showed their history of weights and different stats, and it had a history of the different notes that the doctors had made. Even doctors who worked in all around the world would come and see it and say, "Oh, this is quite nice. I'd really like to have this." But it required, we had thousands and thousands of patients. They had to print out like 800 pages a week or something like that to get them into the things. It's a big effort to get them into the folders, and it wasn't on anybody's critical path. So like, when as soon as I left, I would guess the week after I left, they stopped printing these out and putting them in the folders, and it was hard to motivate, even though it had some potential value. In my next place, I think I just got luckier, not smarter. I worked with a much simpler report. It has just one row per patient. So in this case, there were groups of HIV-positive patients who were under treatment and coming for treatment together. Like they would every 4 weeks they would come as a group, and we would print out a report that would show that group. And it was much more compact. It had a column that was useful for attendance, and that was probably like a key success thing. That if this report wasn't working, the nurses who ran the program would complain. They're like, they used it for attendance. It had just a little bit of decision support built in. We had like just one or two, cells where we could write it. We could give just a little bit of history. So it's less useful, but it was used. And last I checked, even a year or two ago, this report was still kind of in high demand and used because it kind of fit into the workflow. There's just a little bit more of a blow up where you could see the alerts and how the history works. For that same program, we produced an unsuccessful report, which was like also kind of a beautiful and initially very well received 2-page management report. Every week we would automatically produce it and email it out to the program managers. We sent it out. We got like fantastic feedback about how useful it was. And then at some point the system broke and it stopped sending out the email. Like nobody complained. And it was pretty clear that like people, everyone's really busy. They get this email on Friday saying, "Here's the report," and just probably rarely opened it because they didn't need it. As a contrast, in that first program I was at, we had a weekly report, and there was a weekly meeting, and every Wednesday that meeting was like at noon, and the informatics team would go crazy to get that report ready, because if people filed into this management meeting, they expected there to be a stack of these 2-page or 3-page management reports that they would take, and then they would go through that during the meeting. And so those reports were really useful because they kind of fit into the management workflow. And when that meeting stopped, those reports stopped getting generated. And so again, that's just all to illustrate that producing useful data and used data are really separate challenges. And thinking about what people not what they need, but like what's going to make it useful, how it fits into their workflow is crucial, I think, to having impact. A little bit later, I started working on more point-of-care systems. So like before I said, this is all, the reports are all after the fact. And then, of course, if you're, especially as PDAs or funds coming on tap, you want to work on systems that give decision support or guidance right at the point of care. And this is a picture of one of those dispensaries I showed you before, where a woman is doing IMCI, that management protocol for classifying and treating childhood illness. But the PDA, this is earlier work before phones were so popular, is guiding them through it. Oops, let me skip around. I'll come back to that. And so what that work is about is that there's quite a lot of protocols that are used to guide care. So it's a little, this is just a graphical depiction of what I described before. I think there's another call out here where, and this is the way a lot of public health is done, is that you have a cadre of health workers who don't have that much training, and you're trying to deploy things at scale. So some expert clinicians will design, on paper, protocols that say, here's how to go through, here's how to classify and treat the person in front of you. And it gives you a question to ask, and then depending on the answer to that, the next question to ask. And so what we did a fair bit of work on was automating that so that you get asked one question at a time, and then when you answer that question, you then, it brings you through the correct branch. And this work is similar to work which is done just for surveys or household surveys where you're trying to collect data, but here the goal is really to improve treatment. And there are a lot of relatively obvious potential advantages. The main one is that you get better adherence to the protocol. That it's been often observed that even if you train people on a protocol and maybe right away they're doing good, but if you come back and look at it 6 months or 12 months or 2 years later, they're often not following the protocol as they were trained on. And this has the potential to increase adherence to it. You get the potential for lots more and faster data. You could use that to improve supervision. It's not easy to update electronic protocols necessarily, but it's easier than paper protocols. And you don't have the constraints of trying to fit something on just one page. You could have a more complicated protocol if you want, because the system is guiding you through it. And we did a preliminary evaluation. This is a picture of one of the PhD students I've worked with for a long time, Brian Dorenzi. And I love showing this picture just because it makes it look like it was all fun and games a bit sitting on the coast of Tanzania. But Brian has always been hard at work and is currently just finishing up his PhD at University of Washington. But I won't go through too many of the details, but he did a preliminary study, which has been backed up by a larger study, where under observation, if you have clinicians using the eIMCI tool, this is the tool that guides you through the protocol, they do a lot more of the investigations that the protocol says to than if not. So if you look at, do they check for chest and drawing, and only 75% of the time do they do that under observation without the electronic tool, but 94% of the time with it. And so I think that's good. It's only part of the battle. And even now, we've shifted a little bit away from really thinking about protocol adherence. And I think in my mind, it's still kind of an open question of how useful that is, because being under observation has a big skewing factor, and the question is why are people skipping these steps? And if they're forgetting the steps, then our intervention is definitely going to help. If they just don't think they're important, then I think over time they'll also start ignoring them on the system. And if they are ignoring them because it doesn't quite fit the situation, if you look at what people do, often they you could tell, or at least many doctors will say, I'm not a doctor, you could tell if a kid's really sick by looking at them. There's sort of the thumb test of thumbs up or thumbs down, that this kid sort of seems apparent. And so they may correctly or incorrectly feel that if they could tell whether they need to do tests for checking for severe pneumonia based on how the child is, and they may be skipping steps that they either correctly or incorrectly really don't think are necessary, but it's unclear that the technology, in my mind, will really make a difference. Again, it depends a little on what's going on. And this slide represents one of the sort of general lessons that reflects what I've just been saying, which we find a lot now. Like when I talk to health groups, this is like the key thing I try to explain about mHealth interventions, is that if you look at a health program that's designed, it might be protocols like I showed before that are for clinicians, or here's like a forms and procedures for a community health worker to follow. They're designed typically by experts sitting in some city, and it says here's all the things that a community health worker or clinician should do. And so what we find is, like, as we start often in our work talking to like those experts, sometimes in a global headquarters like in DC or Baltimore or New York, and then like we go out to the in-country headquarters, and then we talk to the field managers, and then we talk to the community health workers or the health workers, and then work with the community health workers. And in each of those stages, we get a diluted sense from that original kind of idealized sense of what the health program should be to what's actually in practice. So people, don't do, if you look at the program as it's designed, it might require like an hour and a half, session with each client, and that's just unrealistic given the amount of time people have. And so this gap exists just always. Like often, people are training people on programs, and then if you go look at what's happening, there's often seen as this big gap, and that's what people bring in mobile health workers to solve. They want to raise the actual practice to something closer to the ideal practice. But when you automate systems, and this is the point I'm getting at, you really flourish this tension. It's very hard to like have a gap. You have to, if you automate the ideal system and it has every step and along the way, and it requires really long sessions, like that causes real problems in the field. They just can't do it, or they won't do it, or it's a lot of tension. On paper systems, everyone's a little bit happier because you trained on the system, it's maybe not being followed, but there's no real consequence. There's no that direct feedback. And so if you want to introduce mHealth technology, you've got to be willing to sort of think about this compromise. If your system is too ideal and it's impractical, or it's going to be perceived as impractical, then either you've got to find some way to make it happen, or you've got to compromise and say that the system we're going to prescribe is less intense, or has fewer steps, or is less complicated. So let me pause for a second, because I think it was a bit of a complicated, long thing. Does anybody have any kind of questions or comments on that? All right, more lessons. This is just a sort of a cute story that I put in the wrong place in the system to begin with. But we were working in Dodoma, Tanzania, and we had built a phone-based system to improve newborn visits. So a visit by a community health worker to a mother right after birth, and that's a really important time. Like in low-income countries, the first 24 hours of life is the most dangerous 24 hours in anybody's life, and like the first week is more dangerous than, it's like 25% of the mortality that happens in the first year or in the first month happens in the first week, and then 25% of the mortality in the first year happens in the first month. So those first hours or days are really, really significant. So you want to get a community health worker in there quick. We had developed this module. We were working with community health workers who were already using our system for other kinds of visits, and we just couldn't get, like they just weren't reporting a lot of births. They weren't doing pregnancy care beforehand, and like they were saying, oh yeah, there's a birth now and then, and it just didn't add up. Like we were running the numbers of like how many people had to be born in this population. And then partly because we just wanted to test our system, we said, okay, we'll give a gift to the mother of like a package of diapers and soap and a kanga, a kind of traditional clothing, if we get in there within 24 hours of birth. And then like everything changed. We got like the community health workers reported more births than we thought there could be in our kind of area. I think they were going outside of our area. And we got like 3 to 5 births a day, which was great for us to give us a lot of ability to test our system. And I think in some other context there might be like you might have thought the community health workers were gaining something, and I don't think they were at all. I don't think they were like getting anything direct for themselves. I think they were just finally getting to give something other than advice to the communities. Like they would come in and say, you should take care of the cord, or here's how you should breastfeed, and this kind of stuff, which from our perspective is life-saving. It can reduce neonatal mortality by 30 to 50%. But it's not that welcome to get that kind of public health messaging. You don't want to be told that you shouldn't smoke, or you should put on your seatbelt or something like that. But giving gifts was like, really valued, and created just a lot of excitement. And so, yeah, there's no particular action item that comes out of it, but just that there's a lot of other factors that go into how you do this work. And I think coming close to the end of this section, one of our favorite mantras is to do your design under the mango tree, or I think I had expressed it before as iterate, iterate, iterate. And what we mean by that is that the thing that we've really discovered over the years is that more or less everything we design here, everything design, all the ideas that seem brilliant to us that we design in Boston or New York, they're just all wrong. That we build systems that we're pretty confident we iterate. It could take weeks or months of going through it to get it just right, and then once we start deploying them, it falls apart and breaks. And so what we've learned is, at least our style, is just to get it out in the field much quicker. That build systems, spend we actually in our in working with large NGOs or something in projects, we kind of fight for a large period of time between when we first deploy and when we start a pilot, even to say that's a period of time we want to be doing rapid change. We don't want to be trying to hold the system stable. We want to be working with a small set of users and encouraging them to give feedback and make changes just because they think it'll make it better. And that's how we feel, at least for us, that's how we get to usable systems.
So going off this point, what do you integrate program?
Good question. So we wish we did more. Right now, the majority of code that Dimagi makes is programmed by software developers sitting in Boston. We are supporters and helped start an initiative called Coded in Country, which is very much trying to get at the point of your question of trying to get local developers. If you're working in Tanzania, Tanzanian developers, or if you're working in Botswana, Botswana developers, to be involved in the production of systems. And there's a lot of reasons for it. One is to make systems that are more appropriate. One is it's just one of the best ways to learn something is by doing it. And so if you're putting all this money into building eHealth or mHealth software, it's a lost opportunity to get kind of a second benefit of investing in the training of that country's tech capacities, especially the groups that are kind of interested in development-oriented things. Why it's hard, and the reason why we don't do much of it is, and this is sort of seems so obvious, and you'd be surprised at how often I see plans where I feel like I've got to, or situations where I really have to hammer this home, is that it takes time to build capacity. So you get a lot of projects that want to do two things. They want to build capacity, they want to do things locally, and they want it done in 6 or 12 months. And so you can't use capacity before you built it. So if you work with, there are a lot of places where there's great local talent, or people already, well, everywhere there's talent. Sometimes there's often not very good schools or training, and some places you could work locally for people who already are able to produce software really quickly. But if your goal is to build capacity, then you've got to have more time, at least, maybe not more money, but at least more time to build it before you can get results that you want from it. So we sort of support the initiative or efforts to do it. We think it's really important. It could be some of the best thing that comes out of all this. We'll know later how all these ideas actually take hold. And I'd say Dimagi directly sort of still hasn't quite been able to do it fully. And at the bottom of this slide is just a kind of a shameless plug that's a little bit related to another group that I work with called Spark Microgrants. It's a non-tech initiative, but it's sort of consistent with a lot of things that I've been talking of trying to, we give small grants to communities to be able to identify problems they want to solve and then design a solution that they want to implement to solve it. And so we really just provide some funds and facilitation to get there. And so this kind of reflects the point that it's even though we're also trying to build solutions, we're sort of aware that a lot of this is being kind of designed from the outside. So that's in some ways all background, although I think there's not, it gives a lot of what I want to say about CommCare, is the particular technology that I've been focusing on the most is a tool for supporting community health workers. And I don't know if you all have a sense of just community health programs. In a lot of countries, community health workers are a big part of how health interventions are done. Often people aren't coming to clinics, so you're not going to, if you just build up the clinic infrastructure, unless that increases demand, that won't, directly reach people. And community health workers, people who go, often volunteers or low-paid groups who are in the communities. Often that's the best way to do prevention efforts because you want to get people before they're sick. And so, and as I showed in that one slide earlier, there's a lot of studies that show the potential for community health worker programs. But but it's challenging to run these. They're large distributed workforces, typically not very much training, not a lot of communication points. And so there's challenges of access to care, quality of care, and sort of the client experience. I won't go through so many details, but quite often, not all the eligible people are being enrolled. Like there's a lot of community health worker programs that are focused on maternal care, and not all the pregnant women are identified or enrolled. Often the visits not as many visits as sort of designed or done, and there's often a lot of turnover among community health worker places. If you look at visits, like we've been working a lot in India recently, and a lot of the community health workers have been pretty frank with us and said, yeah, that they were trained to do all this counseling during pregnancy, but they really focus on a few things that are connected to government incentives, like tetanus shots and bringing people to deliver in clinic, and they just had kind of very informal visits, a few minutes here and there during pregnancy. Sensitive topics can often be skipped, things like HIV, and there just isn't a lot of training because it's expensive. And then, a lot of programs are designed with flip books or charts to help engage the clients, but they're big and they're often not carried around. The community health workers are often not that high status in the community, so they're not given that much credibility. And then these systems are just really hard to manage and monitor, much worse than clinic systems. And I'm going to just shift to a video. It might take a second to run. So let me, ignore my messy desktop. But so CommCare is there's two big components of it. The main component from the community health workers' point of view is a phone-based system that it's an application running on a phone. It's about a $75 phone in India, maybe a little bit more expensive in places like Tanzania. I'm just going to skip around this video a little bit, but the idea is that a community health worker uses it pretty much instead of forms and flip books with pictures, and here they're going through a bunch of different forms that they can provide. It keeps a small client list. So in this example, this community health worker has 4 pregnant women that she's following, and then she's decided to do a follow-up visit on Divya, and she's looking through a little client record that's stored on the phone. As soon as she sort of accepts that she wants to do this form on this one, then it brings her through just basically a series of checklists. In some ways, this is no more than just kind of a glorified automated checklist system. After some experience, part of our iteration is the very first question is to make sure it's the right person. So we have the woman's name. That's not a picture of her; it's just a generic picture, but at least the woman's name to make sure you're on the right person. And then it goes through and has images and text, and often there's a question involved that you could say yes or no to. It could be other things. Here they're asking, did you have your first antenatal visit? And then if you say yes, it'll ask if you had your second. For each section, I'm not going to play it, but there's a recorded audio clip that the community health worker can optionally play. So they're just showing the images to the client, and then she could play these audio clips. And adding audio and multimedia was just done really in the last year or so. And we used to have just text-based systems, and now we can't bear to look at our old systems. And really, it's transformed things into making much more of an educational tool, much more of an engaging tool. And the audio has been particularly powerful because you could craft your messages a little more carefully. It's just powerful to hear kind of a slightly more higher authority status person saying it. Here I'm showing you that it's mostly done in Hindi. Oops, just go forward. This video is in English, but usually we just run in Hindi or whatever the local language is. And then all this data is then any data that's collected during a home visit is sent to our central cloud, which keeps a record of each client and those when they were visited, when they should be visited. Our system does backup and reporting, and it allows you to author tools. If you went to comcarehq.org, you could create your own CommCare module, sort of like SurveyMonkey, but more complicated. Although in theory you can do that, and hopefully in some number of months it'll be an easy task. Right now the tools are still a bit clunky, and I think everyone who's doing it successfully is doing it through contact with our developers. We're still working through that. And then just to go through briefly what the advantages of CommCare are, hitting those 4 problems I said before is that we improve quality of care. We have checklists and decision support, which builds on that earlier work I showed you, where I think for things like checklists and just remembering to make each point, there is a little bit of forgetting that happens, and a little bit of prodding I think is effective, maybe a little bit more than for complicated protocols. Sensitive topics, you can have the audio clips to broach them. It doesn't, some people are still going to be not happy to play those sensitive topics about HIV, or feel not that they don't have the training to answer questions on it. So there's no perfect solutions, but it helps. We found the multimedia to be really engaging. Like women really, the clients really lock into the audio and the images. And preliminary evidence is that having the phones in the system increases the credibility of the perceived credibility of the community health workers. And then we can improve access to care for things like we know when people should be visited, we could send reminders, we could send encouragement. We believe we'll get higher retention because the phones add a little bit of status and some skill building. And then there's a lot of potential for data-driven management. I won't talk about it too much, but you have all this data now, and you could really, you get real-time data. You really have the ability to feed that back if you take extra steps to use that data into program management that wasn't had, especially for community health worker programs. Usually the data is pretty poor. I think I've already shown you the video. Just coming back to this question of does it work? We have some preliminary studies showing that some nice results. This is more recent work done by Brian Drenzy, who had done that early work on protocol adherence. And we read a study where we had about 90 community health workers, half of them all using CommCare, half of them got reminders with an escalation to a supervisor. So that this is community health workers who were supposed to visit their clients every month. And so on day 27, they would get a reminder saying you should visit this client tomorrow. And then if they didn't submit a form saying they had done the visit, they would get more reminders. And then around day 3, they would get a SMS saying, a text message saying, tomorrow your supervisor will follow up on you, if you don't submit the form. And I think this graph is makes it look a little bit too good than it actually does. But you got this, very dramatic effect that the full system with SMS supervisor created, significantly better follow-ups than without it. And then we did a second study where we took out the supervisor component, and then that really seemed to revert to the norm. And the supervisor didn't trigger that message that much, and there wasn't actually a huge spike at day 3. Last I looked at the data. But I think once it was known that there was a real person in the loop and the supervisor would call, it just made people sort of more mindful of the whole system and do their visits. Even if you look at the group that was getting the intervention and you look at their rate of being early, doing their visits on day 26 or so before they even got the reminder, it went up just because they're generally kind of know that this reminder is coming. And I think part of it is even though the system was kind of very automated and clinical, we designed it kind of quickly. In some ways, it feels good to know that somebody cares if you're doing your job. And so I think it's not all, having feedback and having somebody do it also just makes it also, makes it more clear that the work is important. Next steps of that work are to, try positive feedback and other kinds of variations to encourage other things besides just missed visits, like enrolling more people, and to try other methods, besides just kind of this kind of reminders and alerts to supervisor to see how you could improve performance. We believe, really significant components of all this is the experience for the community health worker and the client. Deepti has done some investigations of our system and other systems, and I think we'll be reporting back. But what we expect to see is both that the multimedia is highly engaging, and that some aspects, maybe just the phone or the audio clips but the full package does increase the community health workers' perception of her credibility and the actual credibility that's perceived of it. Just to mention briefly, there's another kind of nice bit of work done by another graduate student at University of Washington on trying to make use of the data that we've been collecting. And the goal here was to look at distributions of answers by community health workers. So, a lot of our questions are yes/no questions, like, did you give a referral in this household, or is there a malaria net, or something like that. And so either answer, in any given case, any answer is fine. There's, sometimes it's yes, sometimes it's no. But something seems suspicious or surprising or worthy of follow-up if a particular community health worker has a distribution that's really different than the norm. So in this case, the average rate of referrals was 7%, but this community health worker was referring 38% of her people. And so it's just, might be she's got a sicker population, it might be any number of things, but it's worth following up to figure out what's going on. And if it's, even for household surveys or things like that, if your data is coming back very skewed, it's worth following up. And what this supports is what we would call as automated quality control. If you look at a lot of, now that there's all these mobile systems out there that are being used to collect data, I think the most successful ones have teams of people who are looking at it in real time and then following up in various ways to detect both misunderstandings and in some cases fake data. We did a little study where we got our community health workers to generate a bunch of fake data. So it wasn't perfect. Like we just kind of brought them in and didn't give them, just said quick instructions for how to trying to make up data. And then we ran some experiments to see whether we could use these techniques to pick out the fake forms from the real forms. It was actually a bit of a challenge to come up with data that we were sure was real, because we weren't in our program, like it wasn't, we had general data that was collected from households, but we weren't really sure if that was real. And we had some other data from another study where it was done under observation, which we considered the gold standard of real data. And again, just all preliminary work, but good initial results that you could do a reasonable job of picking out with one or two techniques. Both did pretty well for picking those out. And then just to talk a little bit about scale. So like I said, I might have said, we've been standardizing our approach to CommCare. We now have lots of deployments. This is just a partial list, but I've been working in India a lot for the last year, where we've done about 11 deployments in the last 11 months, which is a much faster rate than we had been doing before. And I think this is not maybe of conceptual interest, but in terms of like our day-to-day lives, like we're putting a lot of energy into like how to run this, and really it's more about business models than fundamental things. But just to say briefly, we've taken a much more product-oriented approach. We really try to standardize things. We have some custom jobs that we'll do to do more complicated systems, but we try to get more groups onto the standard software. You could configure the details and the content and the images and all that, but the software itself being productized really lets us do deployments faster and less expensively. We try to get groups going really fast with proof of concepts. It's a bit of we stumbled upon this little trick that has worked very well. We give groups 10 free phones to try CommCare and some free field support to use our system. We got a grant that let us do that. And we're talking big organizations that have hundreds of millions of dollars of annual revenue. So you might think like $700 or $800 worth of hardware wouldn't be that compelling, but it was really compelling. Like these groups really allowed us to start up groups fast. And I think there's sort of two things going on. If we had offered like a free plane ticket of the same value, I don't think it would have been as motivating. That equipment is seen as like it's as a special kind of thing to get, but then also it bypassed a lot of procedures and approvals and stuff like that. Buying phones and procuring equipment raises a project to like a higher level, and this let people just try it without that much risk. We found that really successful. Like more than half of them are scaling and continuing to work on it. We've like standardized our pricing, and we've got planning tools that like we could now send. Here's how you implement CommCare. Here's how much it'll cost you to run it later. So a lot of work. I mean, like tons and tons of work that is nothing to do with the idea or the concept or any of that, but just to get to scale. And then a new thing that we're doing, which builds off some of the things I've been talking about, is an initiative we call active data management. And what we've realized is that, as I've alluded to, is a lot of these health systems aren't prepared to get real-time data. They haven't gotten real-time data before, and so we're trying to figure out, put a lot of emphasis on how we can like deliver really nice, simple weekly reports. How we could bake in the need for these reports into projects as they're being deployed, into the design, into the monitoring plans, and identifying like here's the list of community health workers you might want to follow up on this week, or here's how things have changed from last week. We're still figuring it out, but we want to put a lot of energy on how to do things that really haven't been done that well before, of how to make active use of this data. And we think it'll be mostly automated. Maybe for a lot of cases or the best stuff, there'll be some human analysis that happens that pulls out some things. So that's the whole talk. Thanks a lot for listening, and happy to hear your questions.
You used your app to detect fraud. So once you started detecting, how much fraud was there? Yeah.
That's a good question that we didn't actually didn't ask. So we haven't. We've run our system and we've pulled out a lot of pretty surprising results from every set we've collected, and we haven't yet sort of investigated it thoroughly enough to know what's fraud versus misunderstanding versus something else. And yeah, we're at the early days. Every group has produced a lot of stuff you want to follow up on. We haven't, like, it's a good question. We haven't come up with like a number of like, it looks like 15% or 2% or 40% are doing something wrong. We know in India we have a lot more kind of a focus on these. We have all these like very tiny pilots of 10 phones that we've given out, and we watch the duration of the visits. So like the way what's kind of evolved is there's a lot of feedback loop on that of like a pregnancy visit. If it's too short, if it's like done in 8 minutes, we know that something was skipped or said outside of the beginning and end of our session, and we see that like if that sort of tails off, and then we follow up, and then it goes back up. So we see a lot of that. It's not fraud, but it's shortcutting, I guess, or it seems like it's shortcutting.
It seems that with CommCare, there's two parts that could be of interest. One is the impact on the health worker, and then the other is the impact on the clients.
Yep.
And I wonder if you have a sense of which one is more important, or what are those effects?
Yeah, it's a great question. So the question was, we're hoping to improve things for the community health worker and for the client, and which, how do we think about that? And ultimately, of course, the benefit has to be for the client. We tend to focus quite a lot on the community health worker, partly as a process measure, and I think a little bit of our attitude, right or wrong, is, well, we want to help groups implement their community health worker program better and understand better what's happening. And if your program, if we help you implement it better, your protocols, and it's not improving the community, then you ought to change your program. Like, it's not our job to provide those kind of procedures. Our job is to have you better understand and better, have the workforce work better. So, we'd be pretty happy to show that we can make it, work, have people do more visits and stuff like that. Even if those visits, if it turned out that visit schedule was wrong, we believe there's somebody else out there who's got a good visit schedule that, if it was followed, would have more benefit to the clients. So ultimately, the answer definitely, when we do, ultimately we want to see benefit to the clients, and if we didn't have, somehow we weren't creating that, we would stop. But short-term focus tends to be much more on the community health worker and how they're functioning according to what they're supposed to, and also feeding back, trying to create those compromises we said, where you shouldn't, if you're expecting too much, that ought to be changed. Does that make sense?
Yeah. Is there any thought within the CommCare system, what's being delivered, to vary that, to see whether different apps or whatever ways of presenting the information might make a difference as well?
Yeah, so we're very keen on what we call optimization studies, or component studies, where we would vary, within a population of community health workers using CommCare, we would have different reminder techniques or different encouragement techniques, or male voices versus female voices, and measure the impact of those. We're especially excited when we can measure the impact on data we can collect automatically, just because it's a lot. You can run those experiments much less expensively. And that really, once you get to scale, if you have thousands of community health workers, you can really optimize your system. And that's how I think a lot of systems at scale get better, is by doing that. But also, even let's say male voice versus female voice or other things, you might have to go down to the more expensive client studies to see what's working. So yeah, so the way we think of it is optimizing CommCare, but we're very interested in doing those kind of studies.
How is the data kept secure?
Right, so how's the data kept secure? There's a lot of aspects to that. So So on the back end, we have HIPAA compliance and secure. Secure as anything, just modern techniques for protecting data once it gets into our cloud. On the phone, it's hard to do really good protections. We have password protection. Somebody who really knew what they were doing could hack it. I mean, it's an interesting question. What I would say roughly is that the data typically is much more secure locally than it used to be, because the typical thing is just notebooks. And we've gotten feedback, especially for like sensitive issues like HIV, community members are concerned that like anybody could just pick up this notebook and read it, and not anybody can pick up a phone and read it. That said, like in some of our programs, particularly some of the less sensitive ones like maternal care, I think all the community health workers have the same password, because it's hard, like the first password they've ever had is a difficult concept. So even getting that password protection working is an investment. Did that answer your question, or we can go to other aspects?
I could see your point about the notebooks, but cell phones are much more interesting to steal than notebooks, so it could be likely that would get in the hands of someone else.
Yeah, so continuing here, the good point is the cell phone itself is more of a target, so you're more likely to get a cell phone stolen than a notebook stolen. And we have some protections. Probably a random person stealing a phone is less likely to be able to get into that data than if they looked at it, if they had a notebook. Just another anecdote about kind of our own wrong assumptions. We early in all this, we were trying different models of CommCare, and it was within a case where there was it was community health workers serving HIV positive clients, and we had like 3 different models, and we had different community health workers. We had them each try a few, like they swapped for the one would try one for a week and then try the other for a week. And one of the clients complained, like it was just to our embarrassment, we didn't predict this. He's like, well, you had a different phone last week. Where's my data? Like you typed my data into this other phone. Where's that phone now? And so clients at least did care about where the phone was going, at least in this one case. So yeah, I think it's a big concern. I think we do, and it's not hard to do, the encoding and protections that you can. It's hard to do anything I think super secure on these phones.
So you mentioned relatively quickly that there's an underlying assumption that the people that are intended to be on the other end of the phone are actually the people, the client. I can imagine for most of the things, or for a lot of the things you do, that's likely to be the case. There's no reason why it wouldn't be. But has that been an issue at all? And as you think about other services you might provide, how that could make it a little difficult to do this kind of approach?
Yeah, so I think the question is, we're assuming that we know who's on the other side of the phone, and like for the reminder case, it's a very good example where we sent all these reminders. We got more forms back. That's really all we know we got, is that we got more reported forms back, and it wouldn't be surprising at all if we got a higher rate of fake forms, because we've just been nagging people and threatening them if they don't submit their form. So you might submit the form and not actually do the visit. And I think we have different thoughts on it. In some ways, we know it's never going to be perfect. All these fraud techniques are actually reasonably effective. Like it's hard to fake data very well. So if it's really a case of like faking visits, you could have GPS, for systems, you could analyze the data to detect it and stuff. I think overall, it's the system. This comes back a little bit to Kantaro's point of if you have a lot of distrust and all of this, nothing you do is going to make that much of a difference. I think overall, these systems are only useful if they're implemented in a way where you build trust and you build empowerment and people want to use them, and you can get good communication and feedback lines going. So, so I think it's less of a technology problem, I think, than.
Yeah, but I don't do work in this area, so this may be a completely off target kind of question. But I was wondering, even though there are cultural differences when a cell phone is given to somebody, especially somebody who hasn't had one before, does it become familial or community property? Is it used in a different way that would make it less likely that it's the kind of way we think about it here, being direct contact with a particular person? Also
a good point. So as far as we can tell, within about 12 minutes of giving these phones and people go home, it's not at all uncommon for their sister's cousin to be loading songs and videos onto the phone at a local shop. It's incredible, sometimes how fast that happens. But they always have it back. I mean, I think we've had almost no cases. We have a lot of, at this point, we have a lot of contact with the people we're working with. And in those cases, like, yeah, it goes around, and sometimes the community health workers' children are helping them with stuff. But they in all the cases we've worked with them, like, there have been cases of loss and theft and stuff like that, but they've been taken very seriously. So yes, but they don't just, at least in our case where we've got some touch points, they come back.
Yeah, because in a funny way, I wasn't thinking so much that the implications were that you would get more false reporting and false filing of the reports and attending the visits. It might be the reverse, that the messages, the phone's not in the hands of the person when it goes out, and so it may actually go up.
Yeah, our systems require a couple of days of training for most people to use. So, a better system might be more. If this is really simpler, maybe we didn't have client tracking and all that, you might get more of a kind of a community resource that can be used everywhere. I'd say our systems aren't of that level because they require a fair bit of training to use. But we'd love that to be the case.
You've spoken a lot about child care and maternal care or something. Do you see a system being tied in with, elementary diagnosis of diseases or something of the sort?
Limited diagnosis of what?
Of diseases.
So I and CommCare are pretty focused on these community health workers, and most of the ones we've worked with, they're not doing a lot of sophisticated diagnosis. And even, I've used the word classification a lot rather than diagnosis, because a lot of these protocols are often don't do a full diagnosis. Like, you wouldn't be sure they have pneumonia, you just decide to treat for pneumonia. So I think more for nurses and for slightly higher cadres, the tools can help with diagnosis. Though for some of the reasons I mentioned, I could repeat them. I think we're a little bit more focused on simple referrals or simple checklists and more complicated things. It's pretty, like, an area where it comes up a lot actually is dealing with emergencies. So like a woman is hemorrhaging or something like that, but it's a really an important time where people get training on like how to deal with different kinds of emergencies for a newborn or mother or other cases. And there's pretty clearly defined protocols and manuals, but if you put them on the phone, they're very unsatisfying. You kind of imagine like dealing with like a phone menu system. It's no better than that of like, do this and like the systems the situations are so complex and fast moving or stuff. It's very hard to standardize it in a way that you can walk through it in a step-by-step fashion. You can imagine kind of being in an emergency and like having the system say press 3 if she's feeling better now, and it's it's not going to work. So that's something we'd like to try to figure out is how to provide support for those situations that is not so much like exactly step by step, but probably I would say less control, more supportive, providing useful information, but not trying to like take control of the situation because it's just too hard to do to handle them.
What about something like that's more long term and how do I put it? Manifested as an emergency, something like anemia.
Like anemia.
Yeah.
So say what kind of is that? Do you mean like a chronic care anemia being over multiple sessions, like diabetes, or do you mean like something that you want to ask 7 or 8, like a deep decision tree?
Yeah, a decision tree or something.
Yes, we could program those on. We've had some luck. We're a little more focused on cases where it doesn't typically mean that people, like the community health workers, aren't given deep decision trees to work with. But we could certainly, our systems, you could code up that decision tree and it'll walk you through it. I think figuring out when that's useful is something that we're still working on or isn't in fact really our focus, but the systems work for it. Does that make sense?
Yeah.
Yeah. I think there's slightly different challenges of why people aren't following those decision trees or if those decision trees really apply to this case. Like, my own sense is that quite often if you have a decision tree, and even if you have it like on the wall or you're looking at it, when you're working with a patient, you kind of interpolate from that idealized description to the current case. And you might not really go through every step. It might not be appropriate to go through every step. And so if that's what's happening, our systems don't really yet afford for that because it kind of assumes that the decision tree is exactly right. And so that's sort of a challenge, I think, to really make them useful, assuming they're not always meant to be followed exactly. Sometimes I think they are, sometimes they're not.
What do you do in the areas that are very, very, very distant from good cell connection?
So, yeah, so one of our little comeback lines is that cell connectivity of the networks is expanding much faster than we are. So, it would be okay for us if we couldn't work in areas yet that weren't reached. There's plenty to do in areas that have connectivity. But all you really need for our system, so it's an offline system, so everything gets stored locally. It just uploads as soon as you get to connectivity. So even if there's like a place you could go, sometimes it is like a place you stand or a hill or something like that, then you can do the upload.
It does it automatically.
You could, it's an option. You can have it be, you have to tell it when to do the upload, or it just does it in the background.
So speaking of connectivity, a lot of places in Africa, connectivity is a lot more available than access to electricity. So you have a lot of people who have a hard time charging their phones. So in these areas, how effective is that?
Right. So what about charging the phones? And it hasn't been a huge problem for us. In most places, at least where we're able to work, there's either some local electricity, and people are pretty ingenious about getting their phones charged, or and quite often there's like somebody set up a solar, like a charging station. So it might be a bit expensive. You might have to pay like 20 US cents or something, but there's like somebody's got a solar charger system that you go charge your phones at. We've had problems with like getting our batteries swapped out for less good batteries and things like that at those places, but we now etch our name into batteries. So there's things like that. But so I think we've thought about giving solar chargers. I mean, it's a pretty reasonable solution. It's an extra moving part you have to track. But solar charging is pretty good for cell phones. Nothing perfect, but it's a reasonable. Gets you, I think, 80%.
Thank you everybody for coming. It was lovely to see you all here again. The next talk will be on December 5th. Dr. Tapan Parikh from UC Berkeley will be giving the talk on voice-based internet or voice-based online communities. Hopefully we'll see you there again. Thank you. Good evening. Thank you, Dr.